And in another patient, this is what happened, in that the catheter stayed inside, the central wire stayed inside. So because the central wire snapped, the whole one part of the catheter came out and it stayed inside. And then subsequently, I have stopped using this catheter and I have switched over to Payunk. And everywhere, though there is no, what shall I say, warning that it is not supposed to be tunneled, it is not supposed to be withdrawn, etc. This problem does happen. Anyway, these are the disadvantages. I have shown you some ghastly complications of a stimulating catheter. Nerve location with the needle is quick and easy. I think you have seen enough demonstrations with all the previous speakers, but repeated attempts at placement are a major nuisance. Catheter guided by USG may fail to also stimulate. So stimulation is a major problem. You saw the picture that Bala had projected today about the covering of the nerve, etc. I wonder if there are interpersonal variation in the resistances of these covers, the perineurium, the epineurium, etc., that where in spite of being close to it, as seen by ultrasound, you do not get a stimulation. Whatever it is, you may be near a nerve and you may not get a stimulation. So most of these studies have been done by anesthetists. So where there is a premium on time, the surgeon is breathing down your neck, there is OT time is valuable. So many of them are biased against stimulating catheters because of these considerations. Time, vascular puncture, and patient comfort are the three things which go very much for ultrasound and not for stimulating catheters. But then, when you come to chronic pain, it is a totally different situation. Patient has gone begging for relief for several years. The primary responsibility here is to ensure adequate, lasting pain relief. No procedural inadequacies are allowable. You see your catheter, you see your needle going to the nerve under the ultrasound. Then you pass a catheter which you may or may not be able to follow through for 5 centimeters or whatever it is. Are you ready to believe that this will work when it does not stimulate? That is the question. Now, here is a patient who's got an ulnar claw hand. I have to do a specific block in this girl. Then here was another patient who had an osteoid osteoma. After excision of this, persistent pain. And in this patient, we passed it along the radial nerve actually. Took us some time, but it happened. But the results after accuracy of this kind is wonderful. This is the patient where we passed it along. Sorry, not playing. It's playing? Okay. I can't see it play here. In the computer, it's not playing. It's through the catheter, it's going at 5 and 0.5 and 0.6, which is a good score. Then you also would want to, when you do catheters for a condition called complex regional pain syndrome, I have to see that there is a radial stimulation, there is a median stimulation. So, sorry. So we have to make sure that, is it playing? No, not playing, forget about it. So priorities in chronic pain, oh, it is playing. Okay, you got first the brachioradialis twitch and then the median is still going on. So you do get all these twitches which are well seen, and this is very useful in chronic pain. To me, time is not an issue. To me, a proper block of the nerve that I want, in addition to the other nerves. If otherwise, I could go simply for one nerve. But in pain conditions, there is always recruitment of other areas for pain. So you need a composite block with special attention to some of the nerves. So these little nitty-gritties make it very important to use stimulating catheters in chronic pain. So another thing is, in regional anesthesia, you can pump the patient with 40 ml, 30 ml, whatever mLs that you want. But here you have an outpatient who's ambulatory, who has to go by a public transport. He cannot have a wasted hand like this. He has to go catch a train, etc. So we have many restraints in this. We want a small volume, we want a proper block, we want a sensory block, we do not want motor block. Okay, I will run through the rest. So now coming to, with all these problems, when USG came in, it was welcomed with open arms by regional people. And so then there are studies which have used combination of ultrasound with electrical stimulation. This combines best of both worlds, though Vrushali insists on telling me don't use 2 modalities. I will say I will use not 2 but 3 modalities in chronic pain. I use also image intensifier and dye spreads in these patients because you cannot be too sure in chronic pain. In anesthesia, if your block fails, Bala has already told us you supplement it. Don't expect 100% block. Whereas in chronic pain, I have to have 100% pain relief. I do not have a choice. So I will use multiple modalities, even if it leads to some amount of confusions, if it leads to some amount of extra time taken. So when you use 2 modalities, somebody came up with economics. You're losing the advantage of cost cutting. You are using a costly catheter in addition to using ultrasound. So this is insurance guided hospital practices which are going on. Don't use 2 modalities. So these are the studies which have gone into this. And they have made out also what is the cost. The cost comparison does not compare well to use 2 modalities. Use either nerve stimulator or ultrasound. They also seem to sort of gloss over the fact that ultrasound is a capital investment. Probably these are all American studies where they all anyway have ultrasound machines, so it's always there. Using a new stimulating catheter becomes more expensive. So conclusions are nerve stimulation with needle with a non-stimulating catheter saves time, but stimulating catheters ensure accurate placement. Do you need this level of accuracy for anesthesia? Probably not. Just ultrasound guidance is great. That's enough. Ultrasound is faster, less likely to puncture vessels, better patient comfort. You do not go poking and prodding the patient again and again, trying to get the optimal stimulation. However, often difficult to visualize the catheter in its whole length. You have seen that it may not be very easy to visualize the needle unless you are experienced. So where are you going to visualize the catheter subsequently? So for chronic pain management purposes, stimulation, ultrasound are both very, very useful. Combination ensures a better accuracy and time, but will increase costs. Thank you very much. I hope I have conveyed whatever was supposed to be. No questions later, right? Yes, okay. Oh, together, no?
I request Dr. Vrushali to present a small memento to Madam. Our next lecture is by Dr. Silamban on segmental epidurals. I am told that Dr. Silamban is very passionate about his regional blocks. He is an associate professor at Madras Medical College.